Hello, everyone, and welcome to today's webinar, A Modern Approach to Screening for Monoclonal Gammopathies Using Digital Workflows. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Sebia. To learn more, please visit sebia.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Mark Zaydman, Assistant Professor of Pathology and Immunology at Washington University School of Medicine, St. Louis, Missouri. Mark, you may now begin your presentation.
Thank you so much for that kind introduction. It's a real pleasure to be here. I'd like to thank Sebia and LabRoots for the invitation. Today's talk, A Modern Approach to Screening for Monoclonal Gammopathies Using Digital Workflows, combines two of my passions. Part of my clinical role is providing medical director's services for monoclonal gammopathy diagnostics at Barnes-Jewish Hospital. My other role is that I serve as the clinical faculty in the section of clinical pathology informatics at Washington University School of Medicine. So the application of computational tools to improve laboratory efficiency is a central role and theme in my work. I'd like to disclose that I've received an honorarium for this talk, as well as a different talk related to multiple myeloma testing. I also hold a patent for a method of reducing interference in immunoassays that can pertain to the serum free light chain assay. The learning objectives today are to discuss current evidence-based practices for monoclonal gammopathy screening, to describe a paperless workflow for integrating pathologist interpretation into the testing workflow for monoclonal gammopathies, and then to discuss the impact of this paperless workflow on laboratory operations at my institution. To provide some background, monoclonal gammopathies are diseases of abnormal clonal plasma cell proliferation. These range from indolent entities, such as monoclonal gammopathy of undetermined significance and smoldering multiple myeloma, which are best treated with watchful waiting, to more aggressive entities, such as multiple myeloma and AL amyloidosis, that require prompt treatment, usually with multidrug chemotherapy and bone marrow transplantation. Shown in this picture is illustrating that as this disease process progresses, an important biomarker is the presence of monoclonal proteins within the peripheral circulation. And those will be the focus of this talk today. I'd like to point out that there's a really happy story in this field, which is that outcomes have improved dramatically for patients over the past few decades. And this is thanks to the availability of an increasing toolkit of treatments for patients with monoclonal gammopathies. The figure on the right shows data from the National Cancer Institute and illustrates that the 5-year relative survival for patients with multiple myeloma relative to their counterparts has improved from just below 30% as few as 3 decades ago to nearly 60% in the mid-2010s. Now, this increased survivorship also means that there are increasing demands on the clinical laboratory to provide reliable information to identify patients who will benefit from these therapies, monitor them for progression of their disease. So for offerings from the clinical laboratory, the definitive study remains the bone marrow biopsy, which provides direct histological of plasma cells and characterization of their clonality. However, bone marrow biopsy is invasive and expensive. And so we reserve this study for high pretest probability patients, as well as patients with a known diagnosis at critical time points in their treatment. Outside of those specific use cases, the key diagnostic and prognostic and monitoring study remains the detection of M proteins or monoclonal proteins in blood and urine specimen from the patient. Current guidelines released recently from the College of American Pathology suggest the following algorithm for the initial screening for monoclonal gammopathies. This algorithm starts with the clinician's evaluation of their patient. If there is sufficient clinical suspicion, then they should order serum protein electrophoresis, SPEP, as well as serum free light chain assays. Then, if there's an abnormality on either of these studies, reflex immunotyping and intact immunoglobulins should be performed. This panel is different from prior panels that included a 24-hour urine specimen. And it is also different from prior panels that performed immunotyping upfront. So this panel offers a compromise between optimal sensitivity and the practicality both to the patient and the laboratory. Now, one important caveat here is that this panel should not be applied to AL amyloidosis. Upfront immunotyping is still the recommended strategy. So I'm going to pivot and tell you about our practice at Barnes-Jewish Hospital and our experience with this new digital workflow. First, Barnes-Jewish Hospital is located in St. Louis, Missouri, United States. It's a large adult hospital housing approximately 1,300 beds. And this is a tertiary academic care center associated with Washington University School of Medicine and working in close partnership with 14 other hospitals in the BJC healthcare system. These hospitals reflect practice in both community and academic tertiary care setting practices. At Barnes-Jewish Hospital, or BJH, we offer a number of assays that help detect and quantify monoclonal proteins. For serum studies, we perform protein electrophoresis, immunosubtraction electrophoresis, and immunofixation electrophoresis, as well as the serum-free light chains assay and quantitative intact immunoglobulins. We have a narrower set of offerings for urine studies, including protein electrophoresis and immunofixation electrophoresis. We do not currently offer immunosubtraction on urine, although we are currently partaking on a validation study to bring up this analyte. To get a little more specific, these are the assays and instruments we utilize. For protein electrophoresis studies, we are mainly on the Sebia line of products, and we're doing our protein electrophoresis using capillary electrophoresis technology on the Capillaris 3 instrument. And our preferred orderable for our clinicians is called serum protein electrophoresis, SPEP, with reflex. And this is pretty consistent with the reflexive algorithm suggested by CAP. So we perform upfront protein electrophoresis, and then immunotyping is performed if the patient's sample is hypogamma-globulin-anemic. If this is a new patient and there's an abnormality observed on the electropherogram, if this is a known patient and we observe a change in the pattern from a previous study, or if it's been at least 1 year since the previous immunotyping was performed. There's one more indication that I've not listed here. If the clinicians order a separate standalone immunotyping, we will, of course, honor that request. Now, the decision to perform immunotyping by immunofixation versus immunosubtraction is driven by the pattern on SPEP, as well as the pathologist's comfort with these two different immunotyping assays. We find that most pathologists presented with a clear abnormal peak will prefer immunosubtraction for the operational efficiency to the lab. But there is variation. Some pathologists have adopted this newer assay, while others remain more comfortable with immunofixation. Looking at our order volumes for 2022, we are a high volume testing center. We received approximately 17,500 orders for these tests in 2022. Most of these are coming from the outpatient setting, with a much smaller set coming from inpatients. Predominantly, clinicians are utilizing our preferred order, which is the SPEP with reflex versus the standalone SPEP and immunotyping orders. One challenge we face is that our order volumes fluctuate dramatically from day to day. And this is really driven by the fact that we have a large myeloma clinic that sees patients twice a week. So here I'm just plotting the volume per day for a couple weeks in November 2022. And what you can see is that on the weekends, we might get 3 or 9 orders, while on those myeloma clinic days, we can receive well over 100 orders to process. And it can be very challenging to keep up with that level of volume. Associated with that fluctuation in volume, there's also fluctuation in the indication for testing. Obviously, our myeloma clinic days, we're seeing primarily patients with a known diagnosis of myeloma or another monoclonal gammopathy. And those are, the greatest fraction of our orders. On other days, we might see orders from neurology working up polyneuropathy, or from endocrine working up bone disease or hypercalcemia. Now, it's not reflected in the figure I'm presenting, which is based on order-associated ICD-10 codes that only come with outpatient, where we're missing the inpatient testing indications. Anecdotally, I'll share those tend to be unexplained renal impairment, as well as patients with a noted elevated protein gap. This is all quite relevant information to the pathologist because the pretest probability of detecting a monoclonal protein is going to be very different on Tuesday, Wednesday, Thursday, and Friday. And pathologists often have that pretest probability in their mind when they're trying to interpret subtle defects within a protein electrophoresis study. So this brings us to a problem we had. We really wanted to reevaluate how we could increase the efficiency of our workflow process so that we could accommodate these very high testing volumes that were growing year over year. What we came up with was that we could improve our efficiency by transitioning away from a legacy paper-driven workflow to a new digital-based workflow. This transition occurred in January of 2022. So on the left, I'm showing you our previous workflow. So what would happen is the technologist would run the study. They would then template an interpretation of those studies. They would print the study as well as the most recent prior study, and they would actually print on 2 different colors of paper so that it was obvious which was the current and which was the prior. They would then go to a very large file cabinet and retrieve physical note cards on which was written all the historical results for protein electrophoresis and immunofixation for our known patients. And these note cards would serve as a companion to the pathologist so that they didn't have to spend time digging into patient charts one by one to see the historical results. At this point, the pathologist would come in, sit at the bench with these stacks of papers, and they would annotate the physical sheets. So if they were in agreement with the interpretation, they could sign those, providing their attestation. If they were in disagreement, they could correct the physical copy, as well as request add-on or reflexive testing. Next, the technologist would have to manually transcribe all these results from the paper copy into our laboratory information system. They would also have to manually update these physical history cards with the new results, and then file them back into their correct location in the file cabinet. Now, the new workflow looks much simpler. The technologist runs the study and templates the interpretation, and then the pathologist will sign and validate that interpretation, or change it, or request add-on testing right within the software environment. Once the study is validated, it flows through a digital environment and automatically to our laboratory information system, and next to the electronic health record to land in the patient chart. So comparing these two workflows, you can see we now have fewer steps, and we have eliminated all physical intermediate paper trail that was part of the workflow on the left. So our motivation was to simplify the workflow to improve efficiency. We also wanted to be able to bring the relevant data to the pathologist so they could still be informed when they're interpreting the studies. We wanted to decrease transcriptional errors that are known to be associated with manual transcription steps in the laboratory. We wanted to reduce our waste trail. And as we went through COVID and the unpredictability of staffing, we wanted to be able to enable remote productivity to disaster-proof ourselves in a way. So the strategy was to migrate the pathologist review process from the physical world into the Phoresis software. Phoresis is the software developed by Sebia that triggers the instrument and collects the data. All right, so the major challenge here, looking back, was that while the technologist's workflow has become much simpler, since they don't have to do all these transcriptional steps, the pathologist's workflow has become a bit more complicated. Previously, the pathologist would simply sign a piece of paper and move on. Now they had to learn a digital workflow involving various modules within the Phoresis software. And I'll just highlight up front, this is probably the major limitation of our new workflow, is that we're using a software that was not designed for the pathologist's interpretation. It was designed for data acquisition, and therefore the organization of the software is centered around these different modules corresponding to the different assays. This was not, insurmountable. We just had to explain to the pathologist how to navigate through the different modules to interpret the various studies. So on the right, this schematic outlines the pathologist's navigation. There's a startup process. They then interpret the serum protein electrophoresis studies. This is the main activity of their day. They'll then view urine protein electrophoresis, validate immunofixations, and then validate any immunosubtractions. So the SPEP workflow, this is, again, most of the time the pathologist spends. And so I'll just outline quickly this process, and then the subsequent ones will be pretty similar. So this starts with the pathologist opening the module within Phoresis, loading a work list, and opening a patient study. They are able to review the fraction gating and adjust it if necessary. And then really one of the aspects we love about this process is that they're able to access and directly compare the current electropherogram with all historical results with a direct overlay. I think that's a real benefit to the interpretation of those studies. And we can do that without having to go to a file cabinet of printed historical studies and dig through to find a prior. Next, the pathologist can review any abnormal peak annotations and gating. And then they can review any reflexive testing that was produced. Again, at our institution, we perform both immunosubtraction and immunofixation. So depending on which study was performed, in one click, the pathologist can open up and view that study, and they can add their interpretation and their signature. Now, there's a little difference here for immunosubtraction. They're able to validate right within this workflow. But due to limitations of the software, immunofixation cannot be validated within the SPEP workflow and has to be validated in a subsequent workflow schema. After reviewing these associated studies, the pathologist can either request additional testing, which we accomplish through a note to the technologist within the interpretive comments, or they can go ahead, add their digital signature, and validate the study. One additional problem we've run into here is that the immunofixation images, these are scanned images of physical gels, have to be manually attached. And so we just had to reinforce with the technologist how important it was that they reliably attach those images so that we would have them associated with the studies, both for the interpretation today, as well as if we need to look back in the future. All right, so I went into that first workflow in detail, so the others will move more quickly. The urine protein electrophoresis workflow looks almost identical, with the exception that we do not have immunosubtraction offered at our institution, so all reflexive immunotyping is done via immunofixation. Next, the pathologist needs to go into a separate workflow, opening a different program, in order to validate the immunofixation studies, as well as review any standalone cases. We do occasionally receive requests for isolated immunotyping studies, typically coming from neurology. This is a pretty quick process. One limitation here. In the other workflows, we were able to implement a validation hotkey, which is a nice productivity solution. So you don't have to click, you can just hit a single keystroke, and that's not available within this particular module of Phoresis. The IT validation workflow is similar to that for immunofixation. You can review the standalone cases and validate those immunosubtractions that have not already been validated in the SPEP process. So that's a lot of detail. Let me zoom out. The pros and cons of our new digital workflow. There's a lot to like. We have dramatically decreased the transcriptional work burden on the technician. And as laboratories continue to be squeezed for staff, I think this is the primary value, the real core value of this transition. Theoretically, we've reduced opportunities for transcriptional errors. This is hard to quantify as those transcriptional errors were difficult to detect in the legacy process. We have certainly reduced paper consumption. All the pathologists have been quite the fans of the ability to directly compare the current study to historical studies, going all the way back through the history of the patient. This really helps to know if there's a change in the electropherogram, if that's consistent with the patient's known monoclonal proteins migration pattern. There are a couple of unanticipated benefits. Because we're working in this digital environment, it's quite easy to take a screenshot of the study to share with clinicians when they have questions about how we're interpreting a study or a change that occurred in their patients' results. And it really helps them to be able to see what we're seeing to better understand why we're coming to the interpretation that we provided. Similarly, when we have a very challenging study, we can take a screenshot and consult our colleagues and have other pathologists weigh in on it. Before this digital transition, we either had to take a picture and scan that picture and then share it, or we had to take the physical copy and walk over to our colleague's office. So now we have almost real-time feedback. Hey, what do you think of this study? And then another unanticipated benefit was we were able to set up some very efficient data capture mechanisms in order to facilitate our Part B billing for our interpretations. And I'll talk about this a little more in a following slide. So now, what have been the challenges? There was a lot of build here. We needed new LIS interfaces between Phoresis and our laboratory information system that we did not have because we did not need them for our paper process. There still are many clicks and many modules for the pathologist. This certainly slowed us down compared to the prior process, at least from the pathologist perspective. But this, everyone's become a lot more efficient with a little bit of training. So this issue has lessened over time. There is a learning curve, and the onboarding process takes a little more time for pathologists. And then there are just a couple, wish list items. The user interface varies across these different modules. It would be great if there was a consistent location of the different buttons. And then we did run into an intermediate has been subsequently addressed by the Sebia support. So our data capture for Part B billing. So before January 1st, 2022, we were not billing for our interpretations. And that was for a couple reasons. One was we didn't have enough MD pathologists to sign out our cases, which has since changed. And then second, we just didn't have the resources to print, sign, and scan studies simply for the documentation of our signature. And so we were able to integrate the capture of the pathologist's attestation and have that transmit across the interface from Phoresis to our LIS, and then from the LIS to our EHR billing module. And so now we do, we are able to bill for our interpretation, which has been a sizable new revenue stream, about $350,000 US dollars in 2022 alone. And hopefully will continue to be, that reliable revenue stream. All right, last I'd like to highlight a couple solutions that we've developed for further workflow optimization within this digital workflow. So first of all, I have to say a big thank you to Damian Marquez, who's provided great support as we undertook this transition and really helped us to configure Phoresis to make our work more efficient. For example, he helped us set up an automatic communication to the LIS, so there's no manual clicking of transmit. He helped us make sure that our interpretive comments stay synced across modules. So if we're viewing an attached immunofixation in the SPEP workflow and change the interpretation, when we log into the other module where we can validate immunofixation, those changes are consistent and persist. And this was really important to prevent confusion and dyssynchrony between those interpretations. He helped us configure our database such that we could be in charge of our own user credentials. Even prior to that reconfiguration, we couldn't accomplish that because we were sharing a database with a sister hospital. And that allowed us to provide unique credentials in order to be compliant with requirements in the laboratory. And he also layered atop some quick key productivity tools so that we could move more efficiently through our interpretive process. I have developed a software package that takes these physical history note cards and automates the generation and updating and maintenance of those note cards. So what I'm showing you in this picture on the right, this was the file cabinet that the technologist needed to visit each day and retrieve up to, let's say, 80 different patient cards from their location, and then file them back at the end of the day. This was a very laborious step. What I did is I developed a Python package that runs on a scheduled job that will retrieve all this information from our laboratory database, create a nicely formatted report, and drop it in a shared folder that the pathologist can access and have on a second screen as they're working within Phoresis. So over here you have Phoresis with the current study, and on the next screen is this report, which allows you to historical results without having to visit the patient charts. So the elements that are in this report include some patient demographics, ordering provider information, and all these historical results. As we look to future upgrades to this tool, we will integrate serum-free light chain results, order-associated ICD-10 codes, as well as information to tell the pathologist if the patient has received daratumumab within the prior 6 months. And this will help, as daratumumab, of course, can interfere with protein electrophoresis testing. We had a very talented medical student rotate with us who generated a little auto hotkey software allowing us to program our interpretive comment dictionaries and create little quick texts. And that's what's being demonstrated in the video on the right. This was a great solution to standardize data entry across Phoresis modules and is compatible with our Citrix application instance and easily reconfigurable. For all these software solutions, I'm happy to share source code to anyone who's interested, and you can just email me at the indicated email below. So concluding thoughts, we have successfully transitioned from a largely paper-based to an entirely digital workflow. I haven't shown the data, but our turnaround times have remained stable through this transition. This is not entirely surprising. The key bottleneck for our turnaround time is the fact that the technologist typically works in the morning, and the pathologist is not usually available until the end of day to enter their interpretations. We are currently collecting data to compare error rates pre and post, but do not have a long enough observation period post-stabilization as we've been continuing to optimize our strategy. Wish list for improving this process. If any brilliant programmers at Sebia want to think about this for the next version of Phoresis, I would love to see a separate pathologist and technologist work queue such that a case can be assigned to one or the other. This would really help to stay organized as we collaborate to complete this testing. It would also be great if there was a concept of a case instead of an assay. What do I mean by that? So take our example from surgical pathology, where a specimen can be accessioned under one accession number and then subjected to all the necessary testing to assign a diagnosis. So in this way, the protein electrophoresis, the immunotyping, free light chains could all fall under one concept that could be interpreted and validated together. With that, I would like to conclude by acknowledging various folks at Barnes-Jewish Hospital, thanks to Natalia Ozipov and Jennifer Hayes, who are managers of this section of our laboratory. Thanks to all the technologists on the bench who had to deal with, dramatic changes to their workflows. Thanks to the IT support from James Hugh and the interface and billing teams. Thanks to our WashU pathologists, who again have learned a new workflow. And then thanks again to Sebia, especially Damian Marquez, who has worked with us every step through this transition. And thanks as well to Tammy Close. With that, I'm happy to take any questions, and I look forward to further discussion.
Thank you, Mark, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. We'll answer as many questions as we have time for. So let's get started. Our first question asks, what impact did the new computer-based workflow have on turnaround times?
Thank you, Kaylee. Yeah, as we mentioned, so the turnaround times have largely remained stable. For some patients, we are processing those samples faster. There are a couple that stay on a little longer, but ultimately, when we analyze our workflow, we think that the limitation on turnaround time is more related to the handoff between the technologist and the pathologist and the constraints on their scheduling, rather than the actual time it takes to complete the work.
Great, thank you. Another question we have here, how is clinical information accessed at the time of interpretation?
Yeah, great question. So we've tried to facilitate the pathologist by bringing the information they need to interpret those studies into one centralized report, and that's those digital SPEP cards. So primarily, the pathologist is going to access information within Phoresis, where they'll be able to look at all the prior studies and do direct overlays of those studies, as well as this Excel spreadsheet report, which is going to provide the numeric value for all the prior SPEP, immunofixation, and urine studies. Unfortunately, we still do have to open up patient charts at least several times a day if we have deeper questions regarding the clinical context of the study, as well as treatments such as daratumumab or other monoclonal therapies that might be relevant to our interpretation of the study. So to summarize, in Phoresis, in our associated report, as well as in our EHR.
Great, thank you. I have another question here for you, and this one asks, what proportion of your immunotyping is performed by capillary immunosubtraction versus immunofixation? And how do these results compare, and why maintain both technologies?
Yes, great questions. Thank you for those. So we really try to prioritize immunosubtraction because it is operationally much more efficient to perform. We, I would say, probably do 2 immunosubtractions to every 1 immunofixation. We keep both studies for several reasons. One is that we use both. So the utilization schema is based on the pathologist's preference, comfort, and interpretation of the current study. And we do find frequent cases where an immunosubtraction was performed, but there's still ambiguity. And so the pathologist chooses to perform immunofixation as well. There are concerns related to the sensitivity of the immunosubtraction. Emerging data have shown that real experts in this assay can achieve similar sensitivity as immunofixation. I'm not sure if we yet consider ourselves to be true experts of immunosubtraction, but anecdotally, there are cases where it's really nice to have both side by side. There are instances where the immunosubtraction is more interpretable than the immunofixation, as well as vice versa. And then finally, I'll add that some of our patients are on clinical trials protocols that have specifically asked for immunofixation. So we do keep the assay around for utilization in those cases as well.
Great. We're getting some great questions in from our audience here, so we're going to proceed. This next question asks, do you include any benign changes in the interpretation, such as acute inflammation pattern, beta-gamma bridging, etc.?
You know, we don't typically, that's not entirely true. We don't typically comment on consistent with acute inflammation pattern, beta-gamma bridging. We will note bis-albuminemia for a couple patients that have that benign finding. But I think we tend to be simple as best with our interpretations, focusing on the presence or absence of a restricted peak.
Great. Next question here asks, do your pathologists still look at gels or entirely look at scans and chromatograms? What are your thoughts about complete telepathology for protein assessment?
Yeah. So we do still look at gels. One limitation this brings up, which should be mentioned, the scanned images are not of the resolution that I would be comfortable interpreting for primary diagnosis. So I would say it would be great to achieve a future state where complete telepathology is possible, but I would for sure want to have the validation study to say that we're performing equivalently looking at physical gels versus scanned images. I will say that looking to that future, one unintended negative consequence would be less communication between the pathologist and the technologist. There's kind of an organic exchange that happens when the pathologist walks into the lab to the bench and says, "Hi, how are you doing? How did everything go today? Were there any problems?" So I am a little bit leery that we're going to lose that interaction that occurs in the physical space. But I think having the ability to perform telepathology may be a great tool, both for unexpected issues like COVID, as well as the ability to bring the expert pathologist services into places that don't have the resources to run and interpret their own studies.
Great. Next question here asks, are the pathologists able to log in to the same instance of Phoresis for interpretations while the technicians may be working on something else?
Yes. So yes and no. So they're both able to work simultaneously. We actually have a separate instance that's on our Citrix that the pathologist can access from any computer on our intranet or with a virtual private network connection to our intranet. Then the technologists typically work on the bench, which has a local instance of Phoresis installed. So there's no locking each other out of the application. Now, we do try to discourage working at the same time on the same studies because there's the opportunity to get confused where the pathologist and technologists are changing the same interpretation at the same time. And this is where a data concept of a pathologist work queue and a technologist work queue could help us to stay organized by assigning that study to one or the other.
Next question here. Which LIS do you have? We enter interpretations in Epic Beaker.
We are using Cerner Millennium, and our EHR is Epic.
Great. Next question, do the technologists or the pathologists perform the interpretations?
Yes, both do. So the technologists template the interpretation, and then the pathologist reads behind and either signs if they agree or modifies the interpretation and then signs. This is, I think, a great solution for a couple reasons. One is that I think it's very engaging to the technologists to be involved in that way and to get to interpret and work through the study. But two is that it's also very useful. Having two eyes on the study does indeed catch, errors, data entry errors. And so we continue to have both technologists and pathologists participating in the interpretation process.
Great, thank you. This next question is a bit of a two-part question, so it is a little bit longer. This question asks, what is the workflow related to the LIS interface? For example, is the SPEP numerical data from the capillaries entered and verified separately by the technologist, and then the pathologist's interpretation from Phoresis is interfaced? We use Beaker and have the capillaries interfaced, but the intrep is currently manually entered by the pathologist into Beaker. Each has separate outstanding lists.
So the workflow is that when the interpretation is complete, the pathologist clicks the validation button, and then at regular time intervals, there will be an automatic communication that captures both the numeric values and the interpretive comments and communicates them across an interface from Phoresis to our LAS, which is Cerner. And then in Cerner, we have discrete data elements corresponding to the fraction quantifications, restricted peak gating, as well as the interpretive comment. So these are an automatic flow. There is an option then to hold up the results within our LIS for manual review and verification, or if one feels comfortable, to turn on an auto verification, whereby those results will automatically flow from our LIS to the electronic health record.
Great, thank you. This next question is also a three-part question. Do you have a limit below which you do not provide a concentration of a deductible serum band? If so, what is the cutoff? And what do you tell clinicians if there is a visible band, but the area under the curve is 0?
Yeah, great question. We don't have a hard cutoff. We use the pathologist's, acumen. And part of that reason is that sometimes you could have a sizable peak, but because it's co-migrating, for example, with normal proteins within a beta band, it is obvious that it would be grossly overestimated if we did our typical gating schema. We do place a comment that says quantity too low to quantify if there's obviously a small abnormal peak that we don't think we can accurately quantify. Our clinicians are pretty well-versed in the use of alternative quantification schemes for bands that are migrating in the beta region, for example.
Great, thank you. Next question here. Do you continue to perform immunofixation each time you get a patient with an immunoglobulin that is considered too small to quantitate?
The answer is it depends. So certainly, so a patient with an immunoglobulin too small. So absolutely, if it's the first time we see that patient. And then there's a little bit of practice variation, I will admit, between pathologists. I think probably if you see the abnormal peak, at least let me say in my practice, if I see an abnormal peak and it's a known abnormal peak and we know the immunotype, I don't think there's much value to repeating that immunofixation. Now, if that peak then on a subsequent study goes away, I think it's very relevant to test with the immunofixation to be able to communicate to the clinician if there's still biochemical evidence of that M protein. I think emerging technologies that get at deeper MRD testing, minimal residual disease testing, might make these questions a little bit more moot in the future.
Great. Another question we have here. Does your facility perform immunofixation when the kappa lambda ratio is elevated, but the SPEP electrophoretic shows no obvious abnormalities?
Mm-hmm. Yes, we do. That was not shown on the algorithm, but yes, we do. That's an alternative pathway to immunofixation.
Great, thank you. All right. Next question here. Is the part that's signing by the pathologist required for result interpretation?
I'm sorry, can you repeat that question, please, Kaylee?
Yes. Is the part that's signing by the pathologist required for result interpretation?
It's not required in that we don't have a hard stop logic that will prevent you from validating without your signature. I wish we did, because typically you'll get an email from the billing department that your signature is missing and we'll have to go back in and correct. So I wish we did have a hard stop, because it would help us catch if we ever missed our attestation, but it's not required at this point.
Great. Once an interpretation is validated in Phoresis, could you be able to modify it?
Yes, you can. You can unvalidate and change your interpretation. One caveat there is that if that result has already been communicated to the laboratory information system, then it is necessary to then manually issue a correction to the information system and to the patient chart, which we have implemented just via a manual process outlined in an SOP.
Great. Well, we're going to go ahead and wrap up there today. Mark, did you have any final comments for our audience today?
I just want to say thank you to everyone for your attention and for your thoughtful questions. Thank you to Sebia for the support in this transition and the invitation. This has been an interesting project to work on, and I think it represents kind of a creative solution to dealing with the pressures that all laboratories are feeling right now, which is how are we going to look to a future where we can be more efficient with fewer FTEs. And then the last thing I'll say is, again, if anyone wants to discuss this process or our experience, or would like source code for some of the tools we developed, please reach out by email and I'd be happy to follow up.
Great. Well, thank you again, Mark, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Sebia, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.